Welcome to the Health and Government Operations Committee voting session. Looks like it's vote list number 16. We have two sponsors who have asked to withdraw their bills, House Bill 170 and House Bill 318. Someone like to make a motion?
Move to withdraw, accept the withdrawals of the bills.
Second.
Any discussion? All those in favor say aye. All those opposed, no. The ayes have it. It's unanimous. I forgot the roll call. We'll let Melissa do the roll call and then we'll get on to the harder work.
Pendergrass,
Yes?
Pena Melnick,
Yes.
Bagnall,
Yes.
Barron,
Here.
Belcastro,
Here.
Sondari,
Here.
Carr,
Here.
Charles,
Here.
Chisholm,
Here.
Collison,
Here.
Hill,
Here.
Johnson,
Here.
Kelly,
Here.
Kerr,
Here.
Hipkey,
Present.
Krebs,
Here.
Lewis,
Here,
Morgan,
I can see him.
Morgan,
Here. Got me
Riley,
Here.
Rosenberg,
Here.
Saab,
Here.
Sample Hughes,
Present.
Shalega,
here,
and Lewis Young.
Here.
Okay, so now we will move on to Senate Bill. Oh, we're going to skip House Bill 836 because we're going to work from the Senate bill. We'll begin with Senate Bill 5.
Senate Bill 5 is identical to its cross-file House Bill 28 as passed by HGO.
Move the bill.
Discussion?
Second.
All those in favor say aye. All those opposed, no. The ayes have it. Passes unanimously. I see I see two hands. This is Senate Bill 5. Are those hands against it or did I miss the discussion? Against. Okay, we've got Delegate Riley and Delegate Krebs. Anybody
I
else?
think there were a bunch of votes against it on the House bill. I checked the votes.
Okay, got to keep up with this stuff. Delegate Riley, Delegate Krebs, Delegate Chisholm, Delegate Shalega, Delegate Saab, and Delegate Morgan. Not unanimous. Okay. Senate Bill 13, Tyler.
Senate Bill 13 is identical to House Bill 1193 as it passed.
move it, second,
Is there any discussion? I see two hands still up. Would you take your hands down, Delegates Saab and Krebs, unless you want to discuss this bill? Okay, seeing no discussion, Delegate Kelly, do you want to move this bill? Oh, it's been moved and seconded. All those in favor say aye. All those opposed, the ayes have it. I see no hands in the panel. It looks to be passing unanimously. It passed unanimously.
Yeah, shake it.
What?
Good. Turn your mic off.
Senate Bill 41, Aaron.
This bill was held in the last voting session. Would you like me to describe again what it does, or how would you like me to proceed?
Why don't you do that?
Okay. The bill establishes that a minor who is at least 12 and is determined by a healthcare provider to be mature and capable of giving informed consent has the same capacity as an adult to consent to consultation, diagnosis, and treatment of a mental or emotional disorder by a healthcare provider or clinic. A minor younger than 16 may not consent to the use of prescription medications to treat a mental or emotional disorder. The bill authorizes a healthcare provider to decide to provide specified information to a parent, guardian, or custodian of a minor unless the healthcare provider believes that the disclosure will lead to harm to the minor or deter the minor from seeking care. This bill was in the Public Health and Minority Health Disparities Subcommittee, and it passed 8-3.
Okay, I see Delegate Shalega's hand is raised. Oh, wait, do I want to go to Delegate Penny Melnick? Do you want to say anything about the bill?
I think that Erin, we discussed it before, it's the same one as the House bill, and Erin gave a great summary. Thank you.
Okay, thank you. Delegate Shalega.
Thank you, Madam Chair. I've had a number of parents call me about this bill, and since that House bill is on the floor, can I hold this till the next voting session?
It was held once, Delegate Shalega. I don't think at this point in time I'm going to allow it to be held again.
Okay.
We're in the last week of session. Delegate Kipke.
Thank you, Madam Chairman. On page 2 of the bill, line 30, healthcare provider may decide to provide information to a parent, etc., unless the healthcare provider believes that the disclosure will lead to harm. Wouldn't it be better to say the healthcare provider shall provide information to the parent unless it puts the child at harm?
Delegate Penny Melnick.
I would respectfully say that no, because it actually changes the purpose of the bill. Basically, kids are in very bad situations where their relationship with their parent is not a good one, not a healthy one. So this way, changing it to shall takes the discretion of the healthcare provider and makes it mandatory. And that is not the intent. The intent is to open more doors for these children to be able to speak to a healthcare professional. And I would say that your amendment just changes the entire bill. But thank you anyway, thank you. Respectfully, I disagree.
Delegate Cullison is next, then Delegate Krebs.
Thank you, Madam Chair. So to expound just a little bit on what Delegate Melnick said, I think part of the therapeutic process is building trust. And if the child is reaching out for help to a professional, and we are talking about professionals, then part of building that trust is respecting what the child wants. And I think that professional will take every opportunity to convince the child that it's important that, their parents and guardians understand the needs that they have. But I think if we mandate that they, pass along this information, we sort of undermine their ability to build that trusting relationship with the child as they try to support them through a difficult time. So that's why I would oppose that change.
Okay, Delegate Krebs.
One of my concerns, it doesn't really say in the bill how this child ever gets to this professional, what circumstance. And the example that keeps being used is that these kids are in danger. And I would probably say, I don't know the percentage at all, but all kids have issues. And I would say the percentage of kids that fall into this category are probably very small. And it's the regular kids that just don't know where else to go. They need a little bit of guidance. So where does it draw the difference between a kid that really has parents that don't care or are problematic versus the ones that would be probably the best source for their kid to go to for counseling? I mean, it doesn't really draw a distinction. I've never been able to figure out how this 12-year-old is even finding this person or how this relationship comes to be.
Delegate Penny Melnick, can you answer her question?
Yes, so during the hearing, we heard from Dr. Polsky. And Dr. Polsky, as you all know, is the officer in Calvert County. And he testified how a young lady was taken to his office by I believe it was a relative, and he was not able to treat her for the mental health. and that he was having issues with the mother. The mother would not consent. So the way they get there, and it can happen through school, but we know the school is closed presently. It can happen to a pediatrician who then makes a referral. It could happen through perhaps a clinic where the child is taken by a relative as well. So it depends, but it definitely, those are scenarios that are more likely than not for it to happen.
So all those scenarios that you mentioned, in none of those scenarios, the parents, the child can't drive themselves. So in all those scenarios, they went to a clinic, someone took them. So you're saying someone, a non-custodial relative, took them somewhere to get something done. I'm trying to figure out how this physically happens, how it met.
The bill doesn't deal with how it physically happens, but it deals with opening the door so that it can happen, so the child can seek help in that counseling. And I would say that in most instances, they probably would, get the help through a teacher at school. They will help them get there, or a pediatrician that will help them get there. But the bill doesn't deal with the transportation. You're correct.
So this has sort of happened, the necessity, because we haven't had school, because normally kids in school or they're home. There's not a lot of in between. I just look, there's so many instances, I think, that people that don't have any, they don't have any custodial privileges to be able to take, if a teacher does something with a student, they're supposed to report it to the parent. So in most situations, these people are required to report it to the parent. And I'm just trying to figure out in which situation some other adult would have the ability to take someone else's child somewhere and get them any kind of treatment, no matter what it is. I just don't see the situation for this. It seems problematic.
Yeah, I think I respectfully disagree. Right now, a 12-year-old can talk to anyone. They can talk to anyone. They could probably ask someone for a ride. I mean, that happens. In most instances.
You must live in a different world from me, because I can tell you my 12-year-old child would never be taking a ride from someone else. I think we live in different worlds.
But there are different worlds. That is exactly why we need the bill. That is exactly why we need the bill, because not everyone has the wonderful parents that you are in your household. Not everyone.
I don't need a lecture. I don't need a lecture.
No, but I'm telling you that is exactly what is needed.
I don't need a lecture.
It's not a lecture. I am
My point is,
answering
Okay,
why
I'm
the
going to
bill
cut you
is
both
needed.
off. Excuse me. I'm going to cut you both off now, because Delegate Krebs, you have a way of asking a question 16 different ways in the same breath, and you're not being accepting of the answer. We did let you say your question. I am going to move on to the next person. Delegate
Thank you.
Lewis Young.
Thank you very much, Madam Chair. During the interim, I had a number of conversations with school guidance counselors, mental health professionals, and public health professionals, because this is an issue I'm very concerned about, and even more so during this period of isolation and uncertainty. And this is a topic that many of them touched on, that they said that many children are apprehensive about reaching out for help because they're afraid of their parents' disapproval, that the parents might feel it's a negative reflection on them. And while a parent might appear to be very responsive to a school or a health official, the way they might speak to the child at home could be very different. So I know this is a tough balancing act, but I'm very supportive of giving the benefit of the doubt to that child that wants to reach out for help and might be somewhat fearful of the parent's reaction. Thank you.
Delegate Rosenberg, then Delegate Kelly.
Aren't there other provisions in the law where we allow for a minor to receive medical treatment without the parent's knowledge?
Delegate Pena-Melnick.
Yes, there are. And if you give me a second, I would tell you in Maryland Health General Code, section 2102, a minor has the same capacity as an adult to consent to medical or dental treatment if the minor is married, if the parent of it is the parent of a child, or is living separate and apart from the minor's parent or guardian, whether with or without consent of the minor's parent or guardian, and is self-supporting regardless of the source of the minor's income. Then in another section separately, it says a minor has the same capacity as an adult to consent to medical treatment if in the judgment of the attending physician, the life or health of the minor will be affected adversely by delaying treatment to obtain the consent of another individual. Then in another section separately on its own, a minor has the same capacity as an adult to consent to treatment for or advice about drug abuse, treatment for or advice about alcoholism, treatment or advice about venereal disease, treatment or advice about pregnancy, treatment or advice about contraception other than sterilization, physical examination and treatment of injuries for an alleged rape or sexual offense, physical examination to obtain evidence of an alleged rape or sexual offense, initial medical screening and physical examination on or after admission of the minor in a detention center, and treatment for the prevention of HIV as well. So yes, in many instances.
Thank you.
My pleasure.
Delegate Lewis Young, didn't you already speak?
Sorry, I forgot to put my hand down. I
Okay.
apologize.
It's fine. Delegate Kelly, then Delegate Bandari.
Thank you. And I just wanted to, Delegate Rosenberg in part asked my question. I did want to remind the committee, as Delegate Pena-Melnick did very well, that this has been working and in place for substance use treatment, for STI treatment, for sexual assault treatment for a very long time. To Delegate Krebs's question, in many ways, we do live in two different worlds. I don't talk about this a lot, but I know many members on this committee know, I grew up in an abusive household. It was multi-generational abuse. My mother was abused worse than I was. When we talk about ACEs, which we have in this committee talked about quite a bit and has done many pieces of legislation to try and support these adverse childhood experiences, there are some kids that just have a harder time than others and don't have parents that can provide the type of support that they need. When I was 16, I participated in a program with a social worker through an after-school program. I was able to receive counseling through that, and it changed my life. So I feel very strongly about this bill. The places where kids are getting this treatment are in programs like that, in health centers, in health department programs. That's the testimony that we heard about how heartbreaking it is to have, someone who is a teenager who critically needs mental health services who can't access them right now. And upon further discussion and sort of how this works, my mind works sort of to protect those kids who have parents with challenges who can't parent them, because that's how I grew up. But I did want to really think about, what about those parents like me? Like, I'm trying to parent my kids. I have a lot of empathy for those parents. How would the system work for them? And what I learned was that in this situation, the first meeting with the counselor, a lot of what can happen if they haven't disclosed to the parents, they haven't shared with the parents that they need mental health counseling, a lot of what happens is that provider works with the teenager to give them the tools to build that bridge to the parents, to bring them back, to bring the parents into the conversation, which is exactly what I like to think that multi-generational abuse that I grew up in, I am not doing that to my kids. I'm being the kind of parent that all of us should be. And so this bill allows for that to happen as well. It prioritizes making sure that parent bond is strong, and there's a process for doing that. In that first counseling session, they help the child with the language that the child needs to be able to have these conversations with their parents, and that's incredibly important. So I just wanted to make sure that question was answered for the committee, that, for those parental relationships where the parent should be involved, the process is working and has been for a long time when it comes to substance use treatment and STI treatment and things like that. And we just want to include mental health treatment in that existing process. I think it's a great bill.
Delegate Kelly, followed by Delegate Banderi, followed by Delegate Hill, and that will be the end.
Thank you, Madam Chair. Yeah, I was also not comfortable in the beginning during the hearing. And I figured out after doing the research that it was not taking away the parental right. And the question is to Vice Chair Jocelyn. And I want to make sure that I believe it will make easier for our youth to obtain needed mental health counseling only if a mental health professional deems them mature enough to intelligently participate in treatment when they are in danger or seriously harming themselves or others or victim of child abuse, right? Is that true, Madam Vice Chair?
What was your question? I'm sorry.
My question is like when health professional, they find out that children under the age of 12 are mature enough to intelligently participate in treatment when they are in danger of seriously harming themselves or others or victim of, I don't know whether there is a victim of child abuse or not. And I believe this is an access needed service before lives are in danger, right? We are talking saving the life rather than taking away the parental right. Is that true?
That's correct. It's correct. On page 2 of the bill, line 3, it says that a minor who is, 12 years old or older, who is determined by a healthcare provider, and a healthcare provider is defined in the bill as licensed under the health occupations article and acting within the scope of the individual's license to diagnose and treat mental and emotional disorder. These are people that are professionals. Basically, if they determine that that child is mature and capable of giving informed consent, then they have the same capacity as an adult to consent to the consultation, diagnosis, and treatment. So this is for prevention to help the child. You're absolutely right.
Thank you, Madam Chair. It's
Because
all about
we have
saving lives.
Yes, we have actually suicide is the second leading cause of death.
Thank you.
For that age bracket. My pleasure.
Okay, the last bite at the apple goes to Delegate Hill.
Thank
Except
you,
that I
Madam
think-
Chair.
Okay.
Madam Vice Chair and Subcommittee Chair, as a licensed healthcare provider, my understanding is that with this legislation passes and a 13-year-old, whether I see them unofficially or I see them in my office, who discloses to me that they have some particular mental health concerns, whether they're feeling a little depressed, not actually, on the verge necessarily, because that will become an emergency and different rules would apply, but that without this bill, until I get the parents' permission, I can't make a recommendation to them. And so if they disclose to me, and I think, there's a peer group that you would really benefit from. And I'd really like you to at least think about taking a visit there. And then we can continue to talk about this. I can't do that now, but with this legislation, that 13-year-old can not just ask their neighbors, their best friend's mother or father and disclose to them, but they could disclose to me as perhaps a trusted healthcare professional. And I could help them to find the assistance they're looking for, even while I work, if I think it's appropriate for them to disclose or allow me to disclose to their parents or their guardian or their grandparents or whoever what kind of distress they're under. Is that a right understanding, that it gives me the same ability to help a kid that their best friend's parent who has no healthcare credentials has right now?
That's exactly right. That's exactly right. Their kids are, as I was saying earlier, when I was to explain myself, not everybody is in an ideal situation. And sometimes kids just want help. And this gives you the tools as a practitioner to be able to help that child and get them the help they need. This is in no way, this bill is intended to take the parent out of the equation. In this bill, the parents have the discretion to contact the parent unless it will do more harm than good. but the priority here is the best interest of that child. And we're justified as a public health committee to do so because the data shows that the numbers are going up for suicide with our young kids.
Okay, I think this bill was not moved and seconded. It is my memory. Delegate Penny-Melnick,
That is correct.
would you?
Move the bill, please?
Second.
Second.
We've had the discussion a little out of order, but nonetheless, we've had it. So all those in favor, please say aye, and all those opposed, no, please raise your hands in the panel. I see Delegate Chisholm, Delegate Krebs, Delegate Shalega, Delegate Kipke, Delegate Saab, Delegate Morgan, and Delegate Riley. Did I miss anyone who wanted to vote no on this bill? Okay, the bill passes. Senate Bill 100. Aaron,
There is an amendment on this bill that would add a representative from the Maryland Rural Health Association. And with that amendment, it is identical to House Bill 368 as passed by HGO.
Move the bill.
You'd have to move the amendment.
Move
I'd
the
like
amendment.
Delegate Penny-Melnick to do that. She might have something to say. I don't know, but
No, I think.
I'm sorry. It's the same. Thank you, Delegate Kipke. I'm focused on other things too. Although, is there a second?
Second.
Is there any discussion on the amendment? There are a lot of hands still up. I'm assuming they're from the last vote. Maybe you could take your hands down unless you have a question. Delegate Morgan, you're the last hand I see. Are you wanting to be called on? All those in favor say aye. All those opposed, no. The ayes have it. It's unanimous.
Move the bill.
Is there discussion? All those in favor say aye. All those opposed, no. The ayes have it. It's unanimous. The bill passes. Senate Bill 111. Aaron?
This bill is identical to House
Move the bill.
484.
Second.
Discussion?
Delegate.
All those in favor say aye. All those opposed, no. The ayes have it. It's unanimous. Senate Bill 298. Lisa?
This bill specifies the customer notification procedures the owner of a pharmacy must follow prior to closing a pharmacy for more than 7 consecutive days. The pharmacy owner must post a specified notice in the pharmacy on the pharmacy's website and provide written and verbal notice to each client who picks up a prescription or refill. The notice must include specified information, and the pharmacy must adopt, the Board of Pharmacy must adopt regulations to define closing of a pharmacy and provide exceptions. There are amendments that alter the time frame of the notice requirement from at least 30 days before the pharmacy closes to at least 14 days and strikes language providing an option for mailing a notice to customers.
Delegate Kelly. No, I'm sorry. Yes, Delegate
No,
Kelly.
you're right. Thank you. So the subcommittee discussed this amendment. We wanted to address the concerns that were raised by the independent pharmacies about the time frame and the potential mailing and the complications of that. So we, Delegate Bagnell, with support from Delegate Krebs and Delegate Cullison, came up with this amendment that limited the notice to 14 days and struck the mailing requirements, which satisfied the independent pharmacies. I move the amendment.
Second.
Discussion? Delegate Saab, your hand up?
Yes, thank you, Madam Chair. Just a quick question. I know we have another bill that was very similar. It's Senate Bill 298. I'm not maybe.
This is.
Well, Senate Bill 298. I'm sorry, Senate Bill. This is 111.
Is it? No, this is 298.
We're discussing 298. Yeah.
Okay. Because I don't have it on my vote list. I don't have 298. Back up. Okay.
Really?
Well, you actually went out of order, I think. That's
No, there were a couple of different voting lists. This one was put on the voting list after.
okay. All right. That's why I was confused.
So you
I
might not
said
have the most
I
recent
thought
one.
this was the same bill. Thank you. I'm good.
You okay with it?
Yeah. I just wasn't. I thought
Okay.
those two bills that did the same thing.
That's fine. Yeah, that would be awkward. Anybody else? Seeing no discussion, did we move the amendments, Delegate Kelly?
We did. We did.
We seconded, okay. All those in
Hey.
favor? Say aye. All those opposed, no, please raise your hand in the panel. I see no hands. The amendments passed unanimously.
Move the bill.
Move the bill.
Discussion? All those in favor say aye. All those opposed, no hands in the panel. And I see no hands in the panel. The bill passes unanimously. Senate Bill 514, identical.
Yep, it's identical to 565.
Move the bill.
Vicky,
Second.
any discussion? All those in favor say aye. All those opposed, no. The ayes have it. The bill passes unanimously. I see no hands. Senate Bill 523, Tyler.
Senate Bill 523, as amended in the subcommittee, is identical to House Bill 600 as it passed the House unanimously.
The bill.
Back to the amendments.
Yeah, the
I think we need
amendments
to move the
first.
amendment. Move the amendment.
Delegate
Second.
Kelly, you have anything to say?
And no, it's just a tweak of an
Okay.
amendment and we passed the cross file. Move the
That's
amendment.
All those in favor say aye. All those opposed, no. The ayes have it. The bill passes. I see no hands, so it passes unanimously.
Move the bill.
You're on
Second.
740. Oh, thank you. Discussion. All those in favor say aye. All those opposed, no. The ayes have it. I see no hands in the panel. The bill passes unanimously. Senate Bill 741. This is the bill that we're going to use also for the vehicle we're going to use the same vote for the Bill 836 because they're going to be in the same posture when we get finished discussing this bill. Aaron,
This bill requires the Maryland Department of Health, in collaboration with local health departments, to adopt and implement a 2-year plan to respond to COVID-19 by June 1st, 2021. The department must also develop and submit a comprehensive COVID-19 vaccination plan and convene a Maryland Public Health Modernization Work Group. The department must provide specified funding to local jurisdictions, assisted living programs, home health agencies, and nursing homes. Each assisted living program, home health agency, nursing home, and specified institutions of higher ed must adopt and implement a specified COVID-19 plan. The bill also mandates health insurance coverage of COVID-19 testing and administration without cost sharing, and any funding appropriated under the bill may consist only of specified federal funds. There were amendments that were adopted in the Public Health Subcommittee that strike the public health core from the bill, provide that locals can only use money, can also use the $25 million grants for any other public health purpose related to COVID-19 response for which federal funding is authorized. The amendments add language requiring that the vaccine plan have a strategy for outreach to people who are not getting vaccinated. The amendments alter the Public Health Modernization Workgroup structure and require the workgroup to make recommendations on the establishment of the Public Health Jobs Corps and to also look at the use of federal funds to implement their recommendations. The amendments also add some additional federal funding language to require that the federal funds used are for the specified purposes of the bill. And there's an amendment that there was a bill passed in 2020 that required disclosure of facility fees, and this would delay implementation of that bill by 6 months.
Aaron, oh, that was Aaron.
Thank you, Chairman. We had a really great discussion on this bill. Everyone was able to give their thoughts, ask questions, and actually suggest amendment. The bill actually has on page 18, the line 5 to 8. It basically states clearly that this is all federal funding. There's no state money from the general fund. We work closely with a lot of the parties. The Department of Health, Ms. Heather Scheck was present this morning as we voted this bill out. And it's basically a way to have a coordinated effort so that all 24 jurisdictions can have a strategy. It also helps the local health officers that we have heard from and have had some concerns as well. So I actually moved the bill as amended.
Second.
Is there discussion? No discussion. All those in favor say aye. All those opposed, no. This is on the amendment. I see no hands in the panel, so the amendment,
Madam Chairman,
yes, sir.
I need to be recused from voting on this bill.
You will be recused from voting on this bill. Thank you
Thank
for
you.
letting us know that. Recused, excused, whatever our word is, I can't remember. Then there will be all but one voting for the amendments. Is there a motion on the bill?
So move.
Second. Discussion? All those in favor say aye. All those opposed, no. Please raise your hand. And Delegate Saab will be excused from voting on this bill. It passes unanimously. Senate Bill 744. Tyler.
Senate Bill 744 provides for membership of the State Board of Nursing's Certified Nursing Assistant Advisory Committee, as well as other revising technical aspects such as providing for a quorum, replacement of vacancies on the advisory committee, and other aspects of the board.
Delegate Kelly.
There were no amendments on this. It passed unanimously. Move the bill.
Second.
Discussion? Hearing no discussion. All those in favor say aye. All those opposed, no. Please raise your hand in the panel. The bill passes unanimously. Senate Bill 780. Tyler.
For Senate Bill 780, HGO is the secondary committee behind appropriations. It is identical to House Bill 1003 as it passed the House.
Move the bill.
Second.
Any discussion? All those in favor say aye. All those opposed, no. The ayes have it. I see no hands in the panel, so the bill passes unanimously. Senate Bill 815. Aaron?
It is identical to House Bill 881. No
Move the
Move the
bill.
bill.
Second.
Discussion? All those in favor say aye. All those opposed, no. Please raise your hands. I see no hands in the panel. The bill passes unanimously. Senate Bill 836. Tyler?
Senate Bill 836, as amended in subcommittee, will require the State Board of Dental Examiners to conduct a study and report on certain aspects of the disciplinary process. The amendment, as you'll see, goes through numerous aspects of it, such as the length, the general length, and requiring for explanations of instances when there was a deviation from the average length between, so when the process took longer than usual, and also asks the board to study comparable licensing boards such as other health occupations boards in the state and other dental boards in the country to compare with their dental boards processes, and then provides a report to the General Assembly by November of this year.
Delegate Rosenberg?
Delegate Kelly.
Yeah.
Delegate Kelly, I'm sorry.
That's okay. So we heard this bill, I think only last week, 2 weeks ago, maybe. It was a work group bill. We thought it was really important, but since we don't like to move work groups, we turned it into a reporting bill. But we did direct the dental board to consult with stakeholders, as well as keep the sponsor of the Senate bill, as well as Delegate Krebs, who's had a bill on a similar issue in the House, involved throughout the process of developing the report, and they will have it to us in November. The amendment passed unanimously. Move the amendment.
Second.
Is there any discussion on the amendments? All those in favor say aye. All those opposed, no. The ayes have it. It's unanimous.
Move the bill as amended.
Second.
Is there any discussion? All those in favor say aye. All those opposed, no. The ayes have it. It passes unanimously, and I do see no hands in the panel. Senate Bill 111. Aaron?
Senate Bill 923.
I'm sorry. Yes, Senate Bill 923. Right. Thank you.
No problem. This bill
There it
requires Medicaid to extend coverage for eligible pregnant women with family incomes up to 250% of the federal poverty level for 1 year immediately following the end of the woman's pregnancy. And coverage is required to include dental care in addition to the comprehensive medical and other healthcare services that are already provided under current law. This was in the Public Health and Minority Health Disparities Subcommittee. There were no amendments.
Delegate Penny-Melnick.
Thank you, Chairman. We discussed this bill this morning. What we learned is that currently they're only covered when they're enrolled in Medicaid for 60 days. This would allow it for 1 year. The reason why this is important is because if there's going to be a problem, it happens usually within 1 year. And there is a high maternal mortality rate of women dying in our state. The money is already there. The governor put in the money. So the vote was unanimous, Chairman. I move the bill.
Second.
Is there any discussion?
Second.
All those in favor say aye. All those opposed, no. Raise your hand. I see no hands. The bill passes the committee unanimously.
Just for the record, we discussed that bill this afternoon, not this morning.
Oh, thank you for keeping that record straight, Delegate Chisholm.
I am so grateful. I'll send you flowers for that.
Promise?
If that's the biggest mistake somebody makes in this committee today, that's pretty good. We have two concurrence.
Chairman,
Yeah.
before you start, we've not really voted on House Bill 836.
Oh, is it okay with everybody if we use the bill on the cross file for 836? Remember, we skipped a bill and then I thought that we would use the vote and use the same vote, which was unanimous, wasn't it?
It was unanimous.
Madam Chairman, I recuse myself on that.
Yeah, Delegate Saab recused.
Yeah, okay, so Delegate Saab will be recused and everybody else will vote yes. Okay, thank you for that. House Bill 123, Lisa.
So House Bill 123 is the Preserve Telehealth Access Act of 2021. And the amendments make House Bill 123 identical to its cross file, Senate Bill 3, as it passed the House. On both the committee and the floor, it was unanimous.
Madam
So,
Chair,
yes,
just to remind the folks, so basically what happened was the same day that we were working on the Senate bill and making the amendments to conform the two bills, the same thing was happening in the Senate. So this is the conformed bill that we created the Senate bill to the coming back to us for confirmation. So there have been no changes in the bill.
so I would like a motion.
We're concurring with the amendments.
Right. So I would move to
right.
concur.
Second.
All right. All those in favor say aye. All those opposed no, say, raise your hand. We will concur. House Bill 463.
This is the Maryland Health Equity Resource Act that was passed by this committee earlier. When we went over the bill, we kind of divided into part 1 and part 2. Part 1 was the 2-year grants for health equity resource communities that are going to be authorized by the Community Health Resources Commission. That has remained pretty much intact by the Senate. The big change in the Senate is to part 2, which is who will administer the permanent community health resources communities. The House bill, as passed by HGO, had the Maryland Department of Health doing that, unfunded, because it wouldn't start until for 2 years. So the funding source would be determined. What the Senate did is they're having the permanent health equity resource communities administered by the Community Health Resource Commission. And they did provide a funding source out of the reinsurance fund. So beginning in 2023, there would be $15 million a year for 3 years to fund the permanent health equity resource communities out of the reinsurance fund. So there is a funding source.
Would you like to, Delegate Penny-Melnick. To move
I
to
think-
concur?
I would like to move to concur, Chairman.
Is there a second?
Second.
Is there any discussion? All those in favor? Oh, I see two hands. I see Delegate Shalega first and then Delegate Hill.
Thank you. Aren't we using the reinsurance fund to subsidize insurance for young people?
We are.
So how much is left? Are we using all of it? Are we depleting that fund that made insurance affordable?
No, I don't know the amount, Delegate, but there's something like 200 and something million left or something like that. And I don't know if Aaron has the number, but there's still a lot left.
Yeah, I think the estimates are of like a $250 million surplus. This would be 45 million of that 250 that would be accounted for.
And what are we doing with this 45 million?
This would be funding health equity resource communities.
I thought we already funded them some other way.
You have for the first 2 years, that's through Relief Act funds. So this is 2 years from now, you would be funding the permanent health equity resource communities, $15 million a year for 3 years out of reinsurance money.
Yeah, why wouldn't we wait? I mean, why do we have to do this today? If we already have this health equity project funded for 2 years, why can't, I mean, we don't know what's going to go on with reinsurance. You know, we don't know what Biden care is going to look like. This does not seem prudent.
Let me talk a little bit about this if the subcommittee chairman doesn't mind. There is a substantial amount of money in the reinsurance fund, and the priority for it is reinsurance money. And I wholeheartedly believe that and feel it needs to be done. Beyond that, if we're going to spend this money on some other things, thinking about money that may be extra that we have, then the things that we use the money for, in my opinion, should have a very close relationship to saving money in healthcare. And these clinics are a strategic way to get people care when they need to, not wait until they're in the emergency room in crisis, by putting providers in neighborhoods where care has been scarce, by helping to get minorities involved in healthcare and people of lesser income. So by doing this, we also are subsidizing rates in a way. It's through a different process, but it's still a way, there is a relationship or a nexus to trying to keep people's healthcare costs down.
Well, I appreciate that. With all due respect, Madam Chair, I voted for that bill that is funded for 2 years. And I think rather than doing that, why don't we use that money to reduce the premiums for people who are currently unable to afford their insurance in the exchange? Realtors, small business owners who really are struggling to pay because they work for themselves. Why couldn't we put that $45 million to help them? We're already helping this other group of people for 2 years. We've already made that commitment. You know, you're piling on for them at the expense of these other people who truly, they're paying like $18,000 a year. They need help. So, you know, I would disagree with you with all due respect.
I understand that you might disagree with me. Delegate Penny-Melnick, do you want to add anything to the reason that we need to have predictability in these?
I think that the
HEZs, but they're HECs, so.
Yeah, I think that the Maryland, Michelle Everly and her group, the Health Benefit Exchange, have been working really hard to reduce premium. The premiums have gone down in the last 3 years. As you know, she has tried to, be creative, like the bill that Delegate Kurt had that we voted for. This is another way to help people that are usually uninsured. And it's just the Senate felt that it will give it some type of, predictability and consistency, and they wanted to make sure that it was a priority.
I think these small businesses would like some predictability and help as well.
I agree with you.
We're already helping these other folks for 2 years. It just seems wrong that you're not helping others that really truly are in need and cannot afford their insurance, and they don't qualify for poverty grants. They don't qualify for Medicaid. They're too young for Medicare, and we've disallowed any kind of catastrophic plan for them. Many of them are uninsured because the insurance is too expensive. You're leaving them out, and you're adding more to a group of people that you're already helping.
I think that we done well, Delegate, in the last, I would say 11 years or so, where we have reduced the number of uninsured by more than 50% in Maryland. We also have done a lot for the people that you're describing in making health insurance more accessible. This session alone, we passed the Relief Act, where helped, to help the small business, people that have small businesses, making those loans up to $50,000 into grants. I mean, we've done a little bit of everything this particular session. But this particular group, we still have in Maryland about 350,000 people that are uninsured. They cannot afford to pay any insurance. And this is a way to reach those communities. So it's
I guess we'll disagree, because you're changing the subject and talking about grants for small business that has nothing to do with them paying for their health insurance.
It's all related.
Well, as a small business owner, I would tell you that it's not related.
Delegate Krebs.
Agree to disagree.
Yeah, I'm just a little confused because part of the exchange was to make it on a sliding scale of affordability so people could buy it. So now, or if they didn't qualify for a subsidy that they could afford, then they'd be on Medicaid. So now we're saying we need this because that's not working to give these people an affordable insurance. So I'm a little confused because that's what I thought, like I said, we were doing all along with the Affordable Care Act, is making insurance affordable for everyone. So that's number one. I'm not sure why you not got another program on top of that. And then the second point is this reinsurance. When we started it, it is basically a tax on people that currently have health insurance. And we basically took the federal tax, and when they did away with it, we took it, and everyone, all ratepayers, all providers, all policies are charged this tax. And I thought it was going to be a temporary thing. We've got all this extra money. Why don't we just eliminate what we don't need? And we're basically taking the money and redirecting it to something else, saying it's related. And it seems to me truth in lending would be that we would give the money back to the people that where it came from, that we put this extra assessment on, which is all policyholders of all regular policies, which is keeping their Affordable Care Act policies have gone down, but regular policies have not. They've gone up. And, I just think it's a shell game what we're doing here with this reinsurance pool. I know everybody loves it because it's not transparent and people don't really understand what's happening. But I don't really think it's fair to people that this is being.
Thank you, Delegate Krebs. Delegate.
Thank you, Madam Chair. I just want to make sure I know about the surplus that we have. Was that intended to further the reinsurance in the future here to help folks have affordable policies moving forward? Or what was that surplus for?
Delegate Penny Melnick, do you want to respond? Do you want me to respond?
The reinsurance fund.
The surplus.
There's a reinsurance fund. They have surplus money left. Okay, because we ended up getting more money from the federal government than expected. Mm-hmm. So we ended up with more money. That's why we have a surplus in this fund that was implemented to reduce the premium, the cost of premium.
And do you recall what the governor did with some of the surplus this year, Delegate Penny Melnick?
Yeah, the governor took some of that money as well, and I forget what he took it for. I don't have that.
I believe
that
he
amount.
took $100 million and used it towards Medicaid.
Right.
He did. He did.
Okay, all right, thank you.
My pleasure.
Okay, I see no further discussion. This was a concurrence. All those are, I guess, Delegate Penny, you want to move to concur?
Yes, Chairman, I move to concur. Thank you.
Second.
And we've had the discussion. All those in favor say aye.
Aye.
Aye. All those opposed, raise your hands in the panel. I see Delegate Chisholm, Delegate Shalega, Delegate Krebs, Delegate Morgan, and Delegate Riley. And Delegate Saab. I have 6 noes. Okay. That, I believe, ends the voting session for the day. Is there anything anybody needs to add before I say goodbye? I'll see you on the House floor at 11 o'clock tomorrow.
May I just say something, Chairman? I'd like to thank Delegate Collison for the little bill good. 123 seems to be popping up every week, and she did such wonderful work on that, she and Lisa. So thank you very much for that work.
Well said. Okay, thank you all for a hard week so far, and I know it's going to get harder. Try to keep eating ice cream and cheering yourselves up as we go through the hard stuff. I know that's what I'll be doing. See you tomorrow morning. Bye-bye.